Good morning. Today we'll have a discussion on one round scenario on blunt trauma abdomen with renal injury. Dr. Ganesh Guru, who is second year PGT, third year PGT at MR Bangalore Hospital, will present the scenario. And with us today is Professor Devanshu Sarkar, who is Professor of Surgery Urology at IPGM SKM Hospital. So Dr. Sarkar will take us through the scenario. So Ganesh, you share the screen and just narrate the scenario given.
Good morning, sir.
Good morning.
Sir, shall I read the scenario, sir?
Yes.
40 years old gentleman with a blunt trauma to abdomen came to the emergency with pain abdomen, gross hematuria and with features of hypovolemic shock. How will you proceed? Shall I proceed, sir?
Wait for the question. I will wait, Dr. Sarkar. Just wait. This is a scenario given. Let Dr. Sarkar start.
Okay. This is a middle-aged gentleman with blunt abdominal trauma in emergency with abdominal pain, hematuria, and features of shock.
Yes, sir.
So you are a JR3. You are called to the emergency. So how do you proceed with this patient? Just don't risk management. Yes.
Yes, sir. I would like to follow the ATLS protocol, which consists of primary survey with resuscitation, followed by secondary survey. Based on the response to this, I will proceed with the definitive management.
Okay. So you have resuscitated the patient, and the patient now is out of shock. He is resuscitated. Then what? If this patient, middle-aged, history of trauma, blunt trauma, hematuria. So after you have resuscitated, what are the specific histories you'd like to know from the relatives of the patient, and what are the specific things you want to know, particularly to the renal injury points?
Sir, I would like to know the time of injury, type of injury, mechanism of injury, where the patient is complaining pain and everything, followed by thorough clinical examination from head to toe. While during the primary survey,
No. History is not over. Try to understand. The question is what history will take in relation to the main injury and particularly renal injury. Two scenarios given, pain and hematuria is given. So there are a lot of other things you might be knowing from the patient. So many things in a trauma scenario.
Sir,
one is said is type of injury and mechanism of injury. Time interval between the injury and arrival in the hospital. All are important. What else in the history is important?
Sir, whether this hematuria is continuously progressing or reducing.
Dr. Guru, regarding the type of injury, why do you want to know the type of injury? What is important in case of renal trauma?
Sir,
I am deliberately not asking questions on other abdominal injuries.
Yes, sir.
But, this is a class on renal trauma, so I'll consider renal trauma. So what type of injuries are specifically associated with renal injury?
Sir, if there is any penetrating trauma to the loin region, there are more chances of a severe injury. Most of the blunt trauma to the kidney results can be managed conservatively. Penetrative injury to the trauma is an indication for exploration of the surgery.
Dr. Ganesh, in exam, you should hear or concentrate what the examiner is asking.
Yes.
I have asked a very specific question: which type of blunt trauma abdomen, in which type of injuries have a greater chance of renal trauma?
First, tell us what are the types of blunt trauma in the abdomen? How it can happen? Most common is?
Sir, RTA.
Yes. Most common is motor vehicle accident.
Yes.
Second is?
Accidental falls.
Third is? Assaults.
Physical assault.
So they are basically, out of these three trauma, which trauma you think is more severe, can result in gross renal injury? It can happen. You are saying that blunt trauma is not very severe. Yes, blunt trauma can be from anything from grade 1 to grade 5.
Yes.
So out of this, which injury you think is more serious in nature?
Sir, road traffic accident seems to be more.
Motor vehicle accidents are more serious injuries. This can happen. This can be anything from grade 1 to grade 5. And not all penetrating trauma needs an urgent laparotomy. Yes. That is also over now. And you said second is penetrating trauma. Now what else?
So why there is more chance of injury to kidneys in motor vehicle accident than physical assault? You know the answer?
Sir, kidney usually lies in the retroperitoneum, and the force caused by the motor traffic accidents will be more than this one.
What happens? What is the mechanism of the injury? When you have a motor vehicle accident, what happens? What is the mechanism of injury?
So
This is
primary
basically
impact of injury. And
acceleration, deceleration injury. So kidney is lying within the renal fascia, attached by the renal pedicles. So if you have an impact, there is acceleration and deceleration injury. So that is the main mechanism of injury. Rashakar, is it right?
Yes, yes, it is basically deceleration and acceleration injuries. What happens? The patient stops, but the retroperitoneal organ, especially the kidney, tries to come forward, and it gets torn at the site of attachment with the pedicle. That is mainly the vascular pedicle or the lateral cortex. That is the most important cause of injury in road traffic accident. Okay, so you need to know this. So why do you think you are thinking about renal trauma? What are the signs? If you see in emergency, you will think this patient might be having a renal injury. Specific answers.
Hematuria is the first.
Is hematuria mandatory in all renal trauma patients?
No, sir. Hematuria is not mandatory. It's not on trauma patients. It depends upon if there is a perinephric lumbar loin region pain.
30 to 40% patient may have no hematuria, or some patient may have only microscopic hematuria, not gross hematuria. So hematuria is one. What else? What are other things which will point you towards that patient has got possibly renal trauma?
So the mechanism of the injury. That is
yes, one thing is mechanism of injury. Second, history.
Sir,
what about pain abdomen? Is there any specificity about the renal trauma causing pain abdomen?
Renal pain will be radiating from loin to groin. That kind of pain will be there in renal injury.
So it's a pain mainly localized to the flank and
flanks. It may not radiate. It's not a colic. You're having a injury, there is hematoma, expanding hematoma, cortical injury. So these all can cause a fixed pain in the more confined towards the flanks.
Third, so you have told the mechanism of injury. You have told about the pain in the flank or loin. Third,
so
that is hematuria which the patient has. Okay. So now come to the examination. What are the things you see in examination? I think this patient might be having a higher chance of renal injury. Examination 1.
Sir, on inspection, there will be ecchymosis around the loin region and flank region.
Okay.
On palpation, I might find pain and pain over the loin region.
Okay.
If there is an hematoma on the percussion, there may be a dull note. If the hematoma is, if there is associated with pericarditis, something like that, in auscultation, bowel sounds may be absent.
If there is a gross hematoma,
yes, there also.
Can you palpate something?
Sir, the hematoma can be felt on palpation.
Yes, you can feel a mass in the lumbar region. It can be hematoma, it can be unit extravasation, whatever.
Any other thing? If the patient has an ipsilateral lower rib fracture.
Yes, sir.
Okay. So if the ipsilateral lower rib fracture points to two things. One is the severity of injury, and second is the type of direct trauma to the site that can have increased chance of renal injury. So in emergency, you need to take these histories. You need to examine this. Okay. So this patient had history of road traffic accident, hematuria. He was in shock. You have resuscitated. So you have a high suspicion this patient is having renal trauma. What next?
Sir, if the patient is stabilized, then we will do the investigation, further investigation, like a urine routine along with the CECT imaging of the abdomen.
Gross hematuria, why do you need a routine urine examination? If the patient has gross hematuria, what would you like to gain by asking for a urine to be tested for blood? It is for situation hard to find there is no macroscopic hematuria. You want to confirm macroscopic hematuria. What is more important here?
So CECT abdomen to know the extent of the injury.
Don't forget about the initial ultrasound.
So initial
first is very standard of care. So first can give an idea about there is a perinephric hematoma, other abdominal collections. They are all important. Okay. So don't forget first. Yes. First is most important.
So you will go for a CCT. What do you write in the order for CCT? Exactly what do you write? This is different from
CCT
any
will
other
be
CT.
arterial contrast along with the delayed image we will be taking to know whether the filling of the renal pelvic calyces and everything is happening.
So delayed means what? There are clear description of asking for CT for renal injury. It should be 4 phase.
Sir.
Like?
Sir, first non-contrast followed by
Yes,
arterial
pre-contrast. Arterial phase. Then?
Parenchymal or nephric phase.
Parenchymal or portal venous phase. That is about 70 seconds. And then delayed film after 5 to 10 minutes. So these are the 4 phases of CT exposure you need for correct diagnosis of renal trauma. Why all these phases are important?
So it will help us to rule out whether the renal vascular injury is there or any parenchymal laceration injury is there. Whether the injury is involving to the pelvic calyceal system, everything we will be able to assess from this.
So can you explain which phase we expect what? In arterial phase, what do or nephrogenic phase, what do you expect? In delayed film, what do you expect?
Sir, in
Basically, these
arterial
are-
phase, we will
Yes.
like to know whether there is a contrast extravasation into the intracapsular hematoma or not, whether it is getting opacified, proper opacification is there or not, we will be seeing. Then in the parenchymal
What will
phase,
happen if there is a pedicle avulsion?
so pedicle avulsion, there will be a contrast blush, contrast extravasation. The hematoma will be there, the contrast will be going into the hematoma, the kidneys will not be enhancing properly.
Next.
Sir, in the nephrogenic phase or parenchymal phase, we will be seeing is there any lacerations in the cortical or calcium distortion? If there is anything there that can be found.
Okay.
Sir,
The delayed film.
Sir, delayed phase, we will be able to see the pelvic calcium system and the excretion of this will be able to see.
See, in renal trauma, the idea of doing a CT scan is twofold. One is to rule out any vascular injury.
Yes,
Second is to rule out any contrast excavation, because these are the two determinants which will dictate you whether this patient will go for conservative management or surgical management. But if you go for surgical management, what surgical management? So in nephrogenic phase, the main idea is to see for contrast extravasation from artery on the vein. And in delayed phase, the idea is extravasation from the pelvis or from the PCS. The most important thing is, another most important thing is, one is what time there is contrast extravasation. If a patient has extravasation as 15 minutes film, there is no extravasation in the 1 minute or 80 seconds film, you know this patient is having a contrast extravasation because of urine extravasation. If it is reverse, if the patient has a medial extravasation at 80 seconds film, you know this patient is having a vascular injury at the pelvis. If the patient has a grade 5 injury, that is vascular avulsion, you will find the extravasation, but you cannot see any enhancement of the kidney. So these are the three things, in short, you should see in films. Okay, so if you write a CCT whole abdomen, that is an incomplete examination. You have to have a delayed examination. Okay. Anything else, sir?
Now, something about the grades of injury.
So before that, I'll like to ask him, what are the indications of doing a CT scan in a patient who has suspected renal injury? Not all patients.
Gross hematuria, microscopic
Yes.
hematuria when the patient is in shock, penetrating
Yes.
injury to the loin. If in pediatric age, even with microscopic hematuria, when the patient is not having symptoms of shock, we will take image. We'll go for CCT abdomen.
It's different for pediatric patients.
Sir, in pediatric patient, their mechanism to cope up with the shock is more, so the shock will be presenting late. Further, the kidney lies lower down and is left unprotected by the rib cage. So there are more chances to.
Yes. Pediatric populations are more prone for trauma. Okay. So can you tell me the grades and which system you are telling grades? I was asking grades of renal trauma.
So grade 1 subcapsular hematoma, contusion without laceration. Grade 2 laceration less than 1 centimeter, not involving the pelvic calyceal system, or there may be hematoma confined within the retroperitoneum. Grade 3 laceration more than 1 centimeter, but there is no urine extravasation, and there is a or there may be confined retroperitoneal hematoma. Grade 4 laceration more than 1 centimeter involving along with the urine extravasation, followed by the expanding hematoma, or the segmental injury, segmental vessel injury, which is contained with the hematoma, segmental injury, or injury to the vascular structures, which is covered by the hematomas. Grade 5 shattered spleen, shattered kidney, uretropelvic avulsion, or renal hilar injuries, or complete transection or laceration of the renal vein and artery.
If suppose a patient has 2 centimeter renal injury on the right side, 2 centimeter laceration with contained hematoma on the lateral perinephric space, there is no extravasation, and there is a subcapsular hematoma on the right side, opposite side. What is the grade in this case?
So we will go with the higher grading, like grade 2 of this injury. The side with the higher will be validated first.
No. So if it's both side, it should be 1 grade higher.
Yes.
Yes. Okay. So this was 3. This will be 4, treated as 4. Okay, fine. Do you have any pictures with you to show?
No picture. Yes, exam scenario discussion.
So what next? This patient 40 was trauma, hematuria, but he has been resuscitated. So you ordered a CT scan, and this patient has there is no medial extravasation. I will give different scenarios in patients. One scenario is this patient has a grade 3 trauma, immunologically stable. Second scenario is this patient has a medial extravasation, but the patient has good enhancement of the kidneys. The third scenario is good enhancement, and there is gross contrast extravasation in 10 minutes film. The first is grade 3 injury.
So grade 3 injury, I would like to go for a trial of non-operative management in this patient with the proper IV fluids.
You should use the term trial. Once you have grade 3 injury, the most of the patients are now NOM. It's not trial. It's the mainstay of treatment is NOM.
Like IV fluid, IV analgesics, followed by the patient will be monitored in the ICU setting. The grade hematuria will be routinely monitored, and followed by the imaging of the patient as needed, whether the hematoma is expanding or not. We would like to.
First, come to the clinical things you'd like to see in this patient. Clinical things, investigations, and where do you want to keep this patient? This patient needs an ICU monitoring, or you can monitor in ward also.
Sir, the patient needs an ICU monitoring.
Why?
Sir, suddenly, if the hematoma is getting, the patient may go and collapse suddenly. So we would like to monitor that. The patient requires a good amount of bed rest, proper IV fluids and analgesics. That's why.
Sir, your comment, because this is debatable.
In trauma scenario, if it is a gross renal trauma, you can treat in HDU unit. Fine. Patient should be in a intensive. Patient needs some amount of monitoring. So it may not be mandatory to treat a grade 3 patient in HDU, but if facility is available, yes, you can treat in HDU unit.
So the patient is in bed rest. Okay. So what are the things you would look on daily rounds?
Sir, vitals of the patient along with the patient. When hematuria is progressing or reducing, and the patient pain of the patient, whether the pain is also progressing or not.
So you look for hemodynamic stability, you look for hematuria, and you look for any signs of complications. Okay, these are the 3 things you look for. Okay, so what are the complications can happen in this patient? Grade 3 renal injury, you are managing conservatively. Grade 3.
Sir, grade 3, if there is hematoma, may converted get into infect and become abscess.
Grade 3 is not the right time to convert it to abscess, too early. First thing, this patient might.
Yes, sir.
Yes, proceed.
Sir, the hematoma might get dislodged also.
Then, where to dislodge it? Inside the perinephric space. The first thing you look for whether the hematuria is increasing or not. That is the most important thing. Second is whether the patient is developing tachycardia, patient is developing fever, okay, or the patient has a new onset perinephric collection or new onset lump. The patient, suppose this was a content hematoma then, and suddenly the patient bleeds because of some reason. Okay, so he might go into shock, he might have hematuria, new onset hematuria, he might have a new onset lump. Okay. Second is you are telling about the appearance of fever. I think the patient might be having some sepsis. Okay. Okay. What are the biochemical parameters you'd like to see?
So a complete blood count along with this, which includes hemoglobin and total count, followed by CRP and ESR, which will show the signs of infection, inflammation.
Okay, if you have a normal count, you don't need to do a CRP. Patient is febrile, count is normal, is improving clinically. CRP is not needed. Hematocrit, yes. Okay. So when do you want to discharge? When do you want two things? When do you want to do a repeat investigation in this patient, and what investigation? And if it is normal, when you can discharge this patient with what advice?
Sir, so repeat investigation is also CECT abdomen. And
No, you see, repeat imaging with CCT is not required in all cases. Patient who are deteriorating, you have new onset complications. They are the patient who merit a repeat CT scan. Otherwise, you can manage with clinical and ultrasound monitoring. Do you need CT for re-imaging if the patient is improving?
No, sir. Grade 1, 2, 3 repeat CT is not needed if the patient does not develop any new complication.
That is bedside.
Yes. You evaluate the patients clinically by serial hematocrit, and you can do ultrasound. Okay, if there is no increase in size, no complication, you can discharge the patient. What advice at discharge? When you say this patient is fit for discharge, clinically and
sir, when there is no hematuria,
yes,
clinically the patient is the vitals of the patient remain stable for at least 2 consecutive days.
yes, and there is no hematuria, there is no fall in hematocrit. Okay, you can discharge the patient, and you do not need any further investigation in this patient. Without an investigation, you can discharge. What specific things you should tell the patient at discharge?
Sir, we will advise to a patient to have a proper rest at the home, not involved in the violent activities, to avoid sports kind of activities for at least one minimum, mild sports for 1 month, severe or moderate form of sports for at least 3 months. If there is an occurrence of hematuria, again, if he's noticing any hematuria or the increasing pain or any swelling is increasing, you should return immediately to the hospital.
And second thing is, we tend to forget is development of new onset hypertension.
Oh, new onset.
That is the thing. Why there is hypertension in renal trauma?
So renal trauma, there may be relative renal artery stenosis due to renal injury, or this hematoma which is compressing upon the renal parenchyma for a long time may lead to this, or there may be activation of the renin-angiotensin axis.
Why there is activation of RA axis? The mechanism of hypertension in all cases in trauma is RA axis. Why there is activation? You told it just.
Sir,
Relative
relative
ischemia.
Yes, relative ischemia because of any segmental artery. It's not the main artery, it's a segmental artery. There is relative ischemia because of stenosis, or there is external compression of the kidney because of a large hematoma. What is that condition called? Development of hypertension following a compression on the kidney, you know? That is called Page kidney, PAG, Page kidney. Page kidney is this condition where you can have a hypertension because of external compression. Okay, and the third thing is if the patient develops the arteriovenous malformation secondary to trauma. Okay, so at discharge, you need to tell the patient these things. And the last thing is you check your blood pressure regularly. If you develop a new onset hypertension, come back. The second scenario was a grade 4 injury where there was gross extravasation of contrast material at 10 minutes film. What does it indicate? Gross extravasation at 10 minutes. Two scenarios. One is medial extravasation, one is lateral extravasation. Both this patient has gross extravasation 15 minutes or 10 minutes film, no extravasation in 80 seconds film.
So that lateral acceleration which is coming late is that collecting system injury, and the medial acceleration at 80 seconds, that is any part of the segmental vessel injury, something like that, which is getting contained.
There is no extravasation at 80 seconds. Extravasation in 10 minutes film. One is medially, one is laterally. Laterally, I have told this patient has a PCS injury. Medially, what is the significance?
Partial uretropelvic avulsions.
EPG avulsion.
Yes, this is a UPG of avulsion or a medial pelvic injury. So what next? If you see a medial extravasation, what is the next structure you should see? Because that will change your management. This patient has medial extravasation. You suspect an injury either in the pelvis or in the PJ. So what next things you should see? Look for the ureter, whether you can see the ureter. If you can see the ureter, that means UJ is intact. The patient is probably having an injury at the pelvis. Okay, this patient can be managed conservatively. Maybe this patient need a stenting. But if you see no contrast in the ureter, probably this patient has a UPG avulsion, and you cannot manage this patient, or you should not manage this patient conservatively. Next, if you see a medial extravasation, always look for the visibility of the ureter downstream. Okay. So you are managing this patient, lateral injury, day 6.
Yes, sir.
What are the things you should keep in your mind? This patient might be having these things. I might need to change my management. Day 6, no hematuria, patient hemodynamically is stable. Still, you are not happy with the management.
So if the urine is not draining properly, there may be urinoma formation. So I would like to do stenting if it is a plain urinoma. If beyond the stenting, if it is not regressing, then we can go for a percutaneous nephrostomy.
How do you know this patient is forming increasing urinoma? It's not the urinoma. The urinoma, if the urinoma increases in size, or there are some complications. What are the complications which might lead to surgical intervention?
So if there is any ischemic tissue, we are remaining.
Okay. Here your problem is the patient is having a urinoma. 90% patients, if you manage the patient conservatively, if you have a proper drainage of the kidney lowered down, this urinoma will resolve. But sometimes what happens, because there is an associated hematoma medially or there is some ureteric injury, this hematoma may not resolve. Instead, it might be increasing in size. That is one indication. Or if the patient develops a fever and you suspect the patient is having an abscess or infected urinoma, these are the conditions you need to intervene. So how do you know this patient is, what investigation this patient is having is not going in a way you want to have it, is having complication? How do you know what investigation?
So renal function.
Renal function is normal because the other kidney is normal. You need to do a repeat CT scan in this patient. Okay, when? Is a grade 4 injury? What is the ideal timeline for a repeat CT scan?
So post 72 hours, we can repeat it.
It's not post, it can has 48 to 72 hours. But yes, if the patient is hemodynamically stable, you can do it later also. Just like this patient, 6 days developed a new onset fever or urinoma, you can get a CT scan at this time. So it's a hard and fast rule. You have to do it in 72 hours. It's not like that. Okay. Now you are sure this patient is having the size of urinoma has increased and the patient is having fever. What next?
So the patient is getting an infected urinoma. The patient is going for this. We would like to drain the urinoma.
How do you like to drain the urinoma?
So if it is percutaneous nephrostomy, still.
Percutaneous nephrostomy. What do you think? Only the percutaneous nephrostomy is going to help?
Along with the antibiotics, we used.
That you are giving. So whenever you have a increasing urinoma size, you think that there might be some obstruction lower down. That is the reason the patient is not getting resolved. Okay. So what you do is you put a percutaneous tube, not nephrostomy. Nephrostomy is something which you put inside the PCS.
Okay,
Here your idea is put something inside the urinoma to drain it because it is infected. At the same time, you drain the kidney with a digestion. Or some surgeons will do a pictal placement in the urinoma and the percutaneous nephrostomy. Either way. So this is one thing. The next scenario comes if he has extravasation medially at 80 seconds film. Sorry, one thing was I missed is extravasation medially in 10 minutes film, whereas you cannot see the ureter in this patient. The kidney is vascularized. What is the etiology in this patient?
Ureter
You
not
got my
seen,
question.
ureter not seen, and there is medial extravasation.
so uretropelvic avulsion.
Yes. What is the treatment?
So we want to repair the uretropelvic avulsion followed by stenting.
Okay. This patient needs an exploration. Okay. If you are expert, you can do the exploration right then, or if you are not, you can send him anywhere else, or you can just put a PCN. Okay. Although that is not the ideal treatment, but you don't have any expert urologist support in your center, you can just put PCN, let the kidney drain outside. It can be taken care of later. But the ideal treatment is exploration and anastomy. The fourth scenario is 80 seconds film, medial extravasation. Two scenarios. One patient has a good visualization of the kidney. The second patient does not have any visualization of the kidney and arterial system. First is kidney visualized, medial extravasation, 80 seconds film. What is your diagnosis and how to manage?
So this patient can
This
be
indicates what? Vascular injury.
vascular injury.
So, what is the strategy for managing vascular injury?
So we would try to repair it.
Repair.
Embolization can be done.
If you see the patient having a vascular injury, extravasation is there, but patient is managed with conservative, patient is maintaining vitals, the hematoma is not expanding. Do you think patient needs an urgent intervention?
Yes.
So what should be the strategy? There is extravasation, means there is a vascular injury. If it is grade 5 injury, hilar avulsion, patient may not be managed with just conservative fluid resuscitation. He might deteriorate. But if the patient is manageable with aggressive fluid resuscitation, then is there a role for conservative management?
So we can try, if the patient is hemodynamically stable, we can try and conservative management.
Whatever may be the grade of injury, if the patient is hemodynamically stable, the idea of renal injury is conservative. The indications for exploration is very clear. If you think the patient has a UPG avulsion, immediate exploration other than the delayed exploration because of complication, there is a different thing. Immediate exploration is if the patient has the UPG exploration, it's better to explore. Or if the patient is hemodynamically unstable, you cannot manage the patient by resuscitation, you have to explore. And most of these patients, if we explore, ultimately land up with emergency nephrectomy. So in your case, the patient is hemodynamically stable, you have resuscitated, but on CT scan, you find the vascular injury, but the kidney is well vascularized. Okay, so in these cases, the most common injury is pedicle vascular venous injury, so the arterial injury. What happens in arterial injury? Mostly it is an intimal avulsion leading to a arterial thrombosis. The kidney, you cannot see the kidney vascularity. In this case, you can see the kidney vascularity, but there is a content hematoma. So vascular injury. Even in this case, if the patient is hemodynamically stable, don't do anything. Because if we explore, ultimately, only 5 to 10% cases you can salvage. But if you do not do anything, most of the cases with the content hematoma may be salvaged. Okay, unless it is a pedicle avulsion, you cannot do anything. If you suspect a patient with renal artery thrombosis who comes to you, fortunately within 2 to 3 hours, you can try endovascular stenting. But the success rate is very less. And even if you're successful, this patient will need lifelong antithrombotic. Okay. That is one thing. Suppose you get a patient who has a medial contained hematoma, you cannot see anything, any vascularity, and the kidney is shattered. It's a grade 5 injury. How do you manage? Hemodynamically stable.
So I would like to explore that case.
Again, I am telling you, this is the common mistake you do in exam. Hemodynamically stable, do not explore. That is the bottom line.
Yes.
Stable patient, do not explore unless
Even
you
for grade five.
suspect two things. Even for grade 5, unless you expect two things. One is PCS injury, pelvic fuse avulsion, the first thing. Or second thing, if you think the patient has a arterial thrombosis, even then you do not explore. You do angiography and try to do a stenting. So exploration is not the thing, it's the conservative treatment, even for grade 5 injury. Okay. Most of the cases we need to explore or intervene is because of complications after the initial resuscitation. It can be hematoma followed by shock. There is sudden hematuria, the patient goes into shock. That is one thing. Or it develops some complication in the form of infected hematoma, necrosis, abscess. But even then, it's not open surgery. It's either a pictal placement or a PCN placement or a disease stenting. Okay. Next scenario is you are a JS3 in neurology and general surgery has opened this patient particularly for other injuries, maybe pancreatic injury or any other thing. So you are called, there is a hematoma on the left side. What you will do? What are the things you will think and decide you should proceed or not?
Sir, on table single shot IVP.
On table single shot, is it available in your center?
Sir, no, sir.
No. Okay. So then, what are the things you should see? The patient is in front of you.
Yes, sir. Pulsatile bleeding, pulsatile hematoma, or the hematoma is expanding. That we
Yes. Nothing else. If the patient has a expanding or pulsatile hematoma, you will explore. If you see a big hematoma on the left side, you are sure the kidney is shattered. Even then, do not try to open the hematoma. Why?
Sir, if without having the vascular access control, if you are opening the
Vascularization you may have. Why not? But point is whether we expand the hematoma or not. If the hematoma expand, if you open up,
yes, sir.
then most of the time you will end up with nephrectomy. That's why you should not open up unless you feel that the hematoma is expanding. You can control the vascular pedicle more medially.
So even if it is a type 5 injury, you do not explore. Even if this patient, suppose sometimes it happens, the CT was done, you see a type 5 injury on the left side, the patient needs exploration for other things. Maybe he has a laceration of the colon or something else. They open up and they find a big hematoma and polyp. Do not do anything. Just see whether the patient has an expansile pulsating hematoma. If it is not, whatever big the hematoma is, do not explore. Because if you do not explore, 90% chance you'll be able to manage this patient conservatively. Sometimes you preserve function. Okay, even if there is 30 to 40% kidney tissue preserved and you can manage without any infective complication, the kidney, some portion of kidney will be functioning. Okay. But if you explore more than 90%, you'll end up with doing a nephrectomy. Don't do anything. Examiner, they go on digging this scenarios. Kya karoge? And most of the residents say, I'll go for exploration. No exploration unless there is exploration. Okay, fine. So suppose you see expansile hematoma, so you have to explore on the left side. What are the steps?
Sir, on the left side, sir, we will first we will control the vascular access, then we will open the gerontospacia. We will create a window medial to the kidney along the left side between the aorta and the lower part of the medial kidney. We will create a window. We will tie the vessels. Then once
don't tie the vessel. You explore and take control of the vessels. So before you open the hematoma, you should take control of the vessels. Don't tie.
Hey, Guru, there are specific landmarks where you should give that. See, it's a total mess. It's a big hematoma. So where is the kidney? Where is the colon? And nothing is very clear. So what are the two landmarks which will guide you where to put the incision? How do you go? What do you clamp first or take control of?
So always we should take care of the artery first before vein.
Going to the artery, you need to go to the. So there are two things. One is intramesenteric vein and one is intramesenteric artery. Sometimes along with the perinephric hematoma, there will be hematoma in the midline also along the aorta. So in that case, it is very difficult to look at the intramesenteric artery. But even then, you can make out what is the intramesenteric vein. So ideal situation is you lay the small intestine, clear everything in the midline. You look for the intramesenteric artery and give a small vertical incision just superior to the origin of intramesenteric artery. This is the scenario where there is no hematoma in the midline. What will happen if you give an incision in the mesentery in the superior to the intramesenteric artery? You will reach the aorta. So you go up, and what structure you'll see traversing anterior to the aorta? What is the structure? What structure goes anterior to the aorta transversely? This is the right renal vein. Sorry, left renal vein. Okay, this is the IVC, this is the aorta, so this is the left renal vein. What structure will see is the left renal vein. That is a constant structure if you give incision just superior to the superior mesenteric artery. Okay, so suppose there is hematoma in the midline. You cannot make out anything. You go to the superior mesenteric vein because you cannot see the superior mesenteric artery. Go to the superior mesenteric vein and give a vertical incision medial to the superior mesenteric vein. You'll reach the same place. You go up and dip, you'll see a transverse venous structure in front of the aorta. This is nothing than the left renal vein. So that is the first thing you should try to understand and find out, left renal vein. So if you can find the left renal vein, you pull it up, and below this, most of the cases is the renal artery, left renal artery. You have to take control of both renal artery and vein. And after that, you go laterally, reflect the colon medially, and give an incision in the. Okay. So this is a typical exam question. How do you go to the hilum in case of emergency trauma situation? Don't forget this. Okay.
Yes.
Next is. Sir, you would like to ask any questions?
No. Yeah, almost you have covered almost. Yes.
So you have opened the kidney laterally. The kidney lower pool is shattered. You cannot make out anything. The kidney is just shattered, lower pool. What are the options?
So, no. Sorry, if the patient, what is the condition of the patient will also guide the management. If the patient needs a damage control surgery at this moment, then
in the ward, you are in the ward, you have opened up the patient, you have opened up the gerota. So you have to do something.
So partial nephrectomy we can. Yes.
Partial nephrectomy. How do you do a partial nephrectomy? In this case, nephrectomy is already done. How do you repair the rest of the kidney? That is the question.
So the bleeding point will be suture ligated. Then we will close the collecting duct with the delayed observable sutures, followed by parenchymal repair. Then the capsule of the kidney will be repaired.
See, what you do is you take control of the renal artery and vein, clamp it, first artery followed by vein, and you do a necrosectomy, what is there in the lower pole. After that, you will look for any evidence of PCS injury. If it is there, you have to repair this. And after that, you cannot repair the parenchyma because it is shattered. Okay. What you do is you do a rhinorrhaphy. This rhinorrhaphy, multiple stitches in the capsule. Capsule is very tough structure. You just repair the capsule over the truncated lower pole of the kidney. That is called rhinorrhaphy. So repair the pelvis, do a rhinorrhaphy, release the venous clamp, followed by the arterial clamp, and see whether there is any bleeding or not. That's it.
Yes.
So, and the next option is sometimes you might be doing simple nephrectomy also in this case. Okay. I think, sir, this is.
Yes, we have covered almost all scenarios. Yes, these are the approach one should follow. First thing is you should follow that it is a ATLS protocol you should follow. Then if it is a specific renal injury, you confine to the discussions on renal injury part. So this is the approach, and you should be knowing the grades of injury, the investigation required, indication for re-imaging, and the monitoring of patient, and the options for management. Option management is non-operative management. Then is angioembolization for extravasation. Patient is having aortic instability. The initial is not exploration. Initial again is angioembolization. And then not manageable with angioembolization, patient is still bleeding. Then there is a role for exploration. And now the nephrotomy rate is almost 1 to 3%. I think Dr. Sharkar, you have gone through almost all the scenarios. So that is what is required for more than required for a student.
I must congratulate Dr. Guru because he has
yes,
very well.
Yes.
I think we get this kinds of answers from our their senior residentry. I do not expect from this from a JRC. Well done, well done. Well done.
Thank you, Dr. Sharkar. Thank you very much. Any question for anybody? Any question? You see, the important thing is you should follow a standard protocol for answering such scenario for any trauma scenario. And we have not gone through this ATLS protocol. You should be knowing this basic part of ATLS protocol also. Some examiner might spend some time on ATLS protocol. What do you mean by primary resuscitation? Should be A, B, C, D, E. Okay. And then you said the patient is on severe shock. How do you manage the shock in this patient who has got a renal injury? Will you do over-zealous
permissive hypotension, maintaining the systolic BP within the range of 70 to 90?
Mean arterial pressure should maintain to around 65. So in this patient, you should not go for over-zealous resuscitation. Patient having a renal injury with hematuria, over-zealous resuscitation is not required. It can aggravate the bleeding. So you do the resuscitation, give the patient a fluid challenge of 1 liter, and then you can maintain BP to around 100 systolic to a mean arterial pressure of around 65 millimeter mercury. I think if there is no question, we can conclude. Thank you. Thank you.
Thank you, sir. Thank you, Dr. Guru. Thank you.